Hello, my name's Ben Heyworth, pronouns he and him, and thanks to Answer Cancer, I've been asked today to talk about lesbian, gay, bisexual, and transgender health, awareness, and best practice. My background is in cancer, and I'm the Macmillan Survivorship Network Manager at the Christie Hospital in Manchester. I also do a sideline in LGBT and smoking cessation and LGBT and cancer and an honorary lecturer at the University of Manchester, and also work for a small charity called Arts for Health. If you'd like to find me on Twitter, my Twitter handle is @thismorningcall, and my website is www.benhayworth.co.uk. And as I normally do this with an audience who ask me questions as we go along, if you have any questions, please feel free to contact me directly, and I'd be very happy to talk about any of the issues that are raised in this presentation. So, we're going to be talking about the LGBT community, and you've probably heard of the LGBT community. We're talking about lesbian, gay, bisexual, and transgender. But who are those people, and can we demystify what we mean by the LGBT community a bit better? That's what we're going to be looking at first of all today. And how are we going to do that? We're going to look at language and labels. We're going to talk about the difference between sexual orientation and gender identity. Second part of the presentation today is a focus on LGBT health, and I've divided that up into several different sections. So we have mental health, we have sexual health, we have public health, and by that I'm talking about things like alcohol, drugs, and smoking. And we're going to talk a bit about cancer and cancer screening and other serious illnesses that affect all of us, including the LGBT community. And following that, a few slides that really look through an intersectional lens. So LGBT within the BAME or BAME community, that's Black and minority ethnic people, and also older LGBT people. Final section of the presentation is really about what to do if you're a healthcare professional and you want to improve your services and make them more inclusive, more equitable, including monitoring and why that's really, really important. If you don't count, you don't count, so to speak. And also engaging with the LGBT community, reflections for groups and workplaces, which is our summary slide. So I hope that's what you're expecting. We're going to crack straight on. What I like to do with some of the groups that I train and educate face to face is start with looking at some newspaper headlines. It's a really good way of kind of getting into the topic area and just thinking really broadly about the intersection between LGBT and health. And this is one of the headlines that I often use in that context. And this is from The Guardian in January 2018. And this is talking about the proportion of people in the UK identifying as heterosexual falling. And the Office of National Statistics, if I can get it out, suggests that those saying they are heterosexual fell from 93.4% to 93.2% in 2017. Now that's, not a particularly big drop, but I think it does raise some really interesting points. Perhaps more people than ever define themselves as not straight. So if that's the case, should we change our view that people who are not straight is a minority? It's also true to say that LGBT people are definitely more visible, and you'll see them in the newspapers, you'll see them on the TV, you see them in soap operas, you'll see them all over the place. A lot more perhaps than you used to do, and a lot of this representation will be really, really positive. So perhaps that's having an impact on how people identify and define themselves. In terms of people affected by cancer, which is one of my areas of interest, those patients are often older. But as the population ages, perhaps we're likely to see more LGBT people coming into these services, and we need to be ready for this. Finally, do our services treat everyone as presumably heterosexual? Well, if more and more people are defining themselves as not straight, then perhaps our services need to do more than just presume that everybody is heterosexual, as certainly an issue with making assumptions about people's sexual orientation and gender identity. And that's something that we're going to be exploring as we go through the presentation today. Here's another one for you. This is around lesbians and lesbians wrongly being told that they do not need a cervical screening. This was on the BBC News in March 2017, and it suggested that half of all eligible lesbian and bisexual women have never had a smear test, according to research by LGBT groups, which might surprise you. I wonder if any of you have ever seen a screening campaign featuring a same-sex couple or even a trans person. Well, probably not, because they don't tend to exist. And the case with lesbian and bisexual women and cervical screening is a classic one, really, because clinicians used to advise against cervical screening for this group on the basis that the routes of transmission meant that they were unlikely to catch the HPV virus that causes cervical cancer. But of course, that would presume that lesbian and bisexual women were having a certain type of sex that didn't involve male penetration. But you can't make those sorts of assumptions. And we now advise lesbian women to go for cervical screening because it's a safer option. But it does take time for that information to drip down into the community and for people to start to reflect on why they might need to go for screening and to act upon it. And we know that screening uptake is lower from this community. So why do we not then think, let's do some targeted patient information around lesbian and bisexual women that has a broader appeal? And we can discuss how to do that effectively later on during the course of this presentation. Now, this one relates to transgender patients. Now, don't worry at this stage if you're not sure what I mean when I talk about trans and transgender people. We'll come on to that and demystify that shortly. But this one from The Guardian in October 2016 was suggesting that the Royal College of Nurses survey points to inadequate training, with only a fifth of the workforce saying it's received relative training and experience around managing trans people. And that's not very many people. Now, lucky for you, you are at this moment enjoying some training around these issues, and we're certainly going to explore this in more detail. But of course, the implication is that there's a proportion of people out there who identify as trans that our nursing workforce feel incapable of managing appropriately, and that can only mean a negative impact on the care that trans and non-binary people receive. And here's one around end of life. LGBT people face devastating discrimination in end of life healthcare, research warns. Some big words in there, some dramatic words. This is from The Independent in June 2016, and it suggests that discrimination and lack of staff training is causing many LGBT people to feel isolated, ignored, and anxious in the healthcare system. And of course, it's worth remembering that those people who might be approaching end of life, our older generation, they will have lived through a time when legislation was discriminating against LGBT people. And in fact, it would be illegal to be homosexual, essentially. So why on earth would you come out to a healthcare professional and worry and be anxious about the response that you might receive from that individual? And as you go into a care home, perhaps those anxieties might come to the fore once again. And despite living a relatively open later life, you might find yourself back in the closet and unable to be your authentic self as you reach end of life, which surely will have a negative impact on the quality of care received by that person. So you've heard me use all sorts of different labels and descriptors as I've discussed those newspaper headlines. Some of them I'm sure you will be more familiar with than others. LGBT, lesbian, gay, bisexual, and transgender is pretty much the one that you'll see everywhere. We talk about the LGBT community. Most people know, I think, that when you refer to a gay person, you're referring to someone who feels romantically and sexually attracted to someone of the same sex. When you refer to a lesbian, it's the same, but it's women. When you talk about a bisexual person, it's around someone who fancies potentially both men and both women, regardless of what sex they are. And transgender is really around someone who feels that their gender identity does not match the gender identity they were assigned at birth. But there are other labels out there, and lots of them. And you might find LGBT comes with a Q and a plus on the end, or LGBTQIA, and various other letters get thrown in there as well. And I wouldn't get too concerned about those. It's probably worth thinking, okay, we've got a Q in there on this slide, and that means queer, and queer's on that slide too. And the word queer is a really interesting example because it used to be very derogatory, and used really as a tool for discrimination through language. But the LGBT community have readopted that word and changed how that word is used quite significantly. And now it is a word that is used as an umbrella term to describe the whole of the LGBT community. So you might refer to the LGBT community as a whole as being the queer community, and that's a perfectly legitimate and inoffensive way now to describe LGBT people. And you'll find LGBT people themselves use that phrase queer all the time. Another one on there is non-binary. I'm going to talk about that one quite a lot during the course of this presentation. This is a gender identity term that really refers to people who don't fully identify with 100% masculinity or 100% femininity, and perhaps present in a slightly more androgynous way. And if you think of examples in the media, Miley Cyrus, I think she describes herself as non-binary, does she? Well, you'll have to correct me if I'm wrong about that one, but it wouldn't take long to find somebody in the media who identifies as non-binary, and it's becoming quite a prevalent label that, particularly amongst younger people, to describe their gender identity. And it kind of comes hand in hand with the kind of idea of gender fluidity. So whilst you don't have to be gender fluid and to be non-binary, the idea that you can present as slightly more female one day and slightly more masculine a different day, and inhabit those different gender roles at different times is what gender fluid is really all about. But why do we apply all these labels? Why do we have so many labels? And I think if you're in the mainstream, if you're a straight person or a cisgender person, a cisgender is kind of the straight to the gay, cisgender to the transgender. It basically means someone who does identify with the gender they were assigned at birth. It's really easy to think, well, I don't need labels because I'm just in the mainstream, so I don't need to label myself anything in particular. But for people who find themselves in minority groups, labels become very, very important. They give a sense of belonging, a sense of identity, a way to describe a relationship to others who might be in that group or outside of that group, and they give rise to a sense of pride. And you'll have seen the Pride LGBT festivals all around the world going on, and they're full of labels and full of flags and full of representation, aren't they? On the other hand, you might find that labels do tend to discriminate potentially. Do they reinforce stereotypes? Do they bring a load of assumptions with them? Perhaps negative associations. Oh, you're so gay, it kind of suggests a certain presentation, doesn't it? A certain way of walking, a certain way of holding your hands. Perhaps these are negative, perhaps they're not, but nevertheless, they are assumptions, and perhaps limitations come along with adopting these labels. So there are some negativities in there as well. But so nevertheless, the LGBT community have really embraced labeling themselves, and it's important as healthcare professionals to understand when labels are appropriate, and not get too worried about getting them wrong, but do our best to get them right as and when. And if you don't remember anything else from this presentation today, please bear in mind the difference between sexual orientation and gender identity, because LGBT does lump these two groups together and they're not the same. Sexual orientation is a person's sexual, romantic, or emotional attraction to another person. And what we're talking about here is gay, straight, lesbian, bisexual, pansexual, asexual, and so on and so forth. And it's very much to do with who you fancy. That's the easy way to remember it. Some interesting related terms that I think are worth thinking about before we go any further. One of these is heteronormative or heteronormativity, and this is the viewpoint that heterosexuality is the default or normal. And this is really important because the whole world is essentially heteronormative, isn't it? It's the assumption that everything is straight until you let us know or come out as a gay person. And whilst that's okay on its own, too much heteronormativity leads to something called heterosexism. And this is where the negative vibe comes in, because this is not only the assumption that every individual is heterosexual, but the stigmatization of anything that is not heterosexual comes with it. That's heterosexism. So that's, the schoolyard playground taunt of, oh, you're so gay, is a heterosexist position to take, and not something we encourage, as it leads to much broader discrimination. And I guess the challenge for you all who are listening to this now is to reflect on your own service. If you're a healthcare professional, or perhaps your business, or where, your professional role, and think, is what I'm doing heteronormative? Do I bring a heteronormative attitude with me when I go to work in the morning? Do I make assumptions that might lead to heterosexism? And how can we challenge that? There's a couple more that are on the slide which are very interesting as well. I've mentioned them briefly already. One of them is asexual. Sometimes you see that on the end of the LGBTQA. And this is to do with the lack of sexual attraction to others, but still having the capacity for emotional and romantic attraction. So asexual people are not an emotional void. They just don't have that sexual urge that perhaps others feel so strongly. Pansexual is very, very closely linked to bisexual. Pansexual meaning all, pan means all, I think. Someone with a good Latin background will be able to put me right on that one. But this is someone who's sexually attracted to anyone, regardless of gender identity, expression, or presentation. So a bisexual really is around the binary. I fancy men and women, and the associated presentations, whereas pansexual kind of discards that idea of dwelling on a kind of gender presentation, and instead looks towards the individual, and very open to individual expressions of sexual attraction, regardless of any other labels that person may or may not have adopted. Moving on to gender identity. So this is our internal sense of self as male, female, both, or neither. So very much about gender, nothing at all to do with who you fancy. So the terms that would float under this heading are transgender, non-binary. You might talk about transsexual, and we might talk about cisgender. So I've already mentioned cisgender briefly. I've already mentioned non-binary. Hopefully this is starting to become a bit clearer to you if you've never come across transgender labels before. But some associated terms are on this slide. Cisnormative I've already spoken about slightly, but here this linking it back to heteronormativity. So the viewpoint that being cisgender is the default or norm. So check yourself again. Are we making assumptions that everybody coming through the door is cisgender? And are we inadvertently cancelling trans people as a result? Gender fluid. So this is the idea that gender expression and identity can be fluid. The word fluid is missing off the slide there, I've just noticed, but never mind. And this is kind of associated with non-binary, but you don't have to be gender fluid and non-binary. They don't come hand in hand, but for some reason there is an association there. Trans man and trans women. Trans men were assigned female at birth and now identify as men, whereas trans women were assigned male at birth and now identify as women. So really easy to remember that. The gender in the label, trans man, is the current gender expression. So if you come across a trans man, they were assigned female at birth and are now identifying as male, and the opposite for trans women. You might hear the term dead name come up from time to time. Now, this is to do with the name that might be associated with the gender assigned at birth but has been rejected, is no longer used, is no longer appropriate, but might crop up on a birth certificate or some legal documentation or a clinical record or something. And last but by no means least, you can't not mention drag and drag queens and drag kings. And it's really important to remember that we're talking here about temporary expressions of gender for the purposes of entertainment, for the purposes of fun, for good times. And it is not it is not something that someone's going to adopt as a lifestyle choice as a transgender person. And interestingly enough, of course, you associate drag queens, especially with gay men, but you don't have to be gay to be a drag queen. And being a drag queen has nothing to do with who you fancy. It's about gender. So it's all kind of wrapped up and sometimes quite difficult to unpick. Drag king, incidentally, if you've never come across that one, is around women who will, in the way that men present themselves as really flamboyant women in a drag way, over the top gender expression. For a drag king, it's about over the top masculine expressions. It's women bringing an over the top masculinity to a performance. If you've never come across a drag king, then do Google it and have a little look to see what they're up to. So how do you get to the point of being a trans person? Well, what's going on there? There is a diagnosis of something called gender dysphoria, which, as it says on this slide here, is the condition of feeling one's emotional and psychological identity as a male or female to be opposite to one's biological sex. And just to give you a sense of numbers, there's a few numbers at the bottom of this slide. Now, I can't tell you at the moment how old this data is. I suspect that these numbers will have increased since this presentation was put together, since this research was done. But it does give you a little bit of a sense proportionally of where everything kind of sits. So you've got 400,000 people there regularly experiencing feelings of gender dysphoria. Of these, as many as 100,000, a quarter of them, are undergoing a transition to their true identity. So we're dropping a huge proportion of people before we get into I actually want to transition type conversations. Okay. And of those 100,000, we've got 10,000 of these people will discuss their desire to transition to medical professionals. So again, huge numbers dropping off, and 6,000 people who will complete that transition. So the big question is, of course, do the original 400,000 people who regularly experience feelings of gender dysphoria describe themselves as trans? Well, that's not a question as a cisgender person I can answer. Only they can answer that question, which is why it's really important to identify who's trans in your service and who isn't via monitoring. And that's something we're going to come on to later in the presentation. What does it mean to transition? What does it mean? It's a serious undertaking, okay? At the very least, you would be having psychological and talking therapies to get the ball rolling at the start of your transition, your trans journey. And just to set the scene, or maybe to prepare yourself mentally and emotionally, and to talk you through what's going on and to reflect and to see how you feel, and to make sure your head is in the right space for something. Because when you start getting into hormone treatments and surgery, these are pretty invasive, long-term, serious body changing things that are going on, and waiting times and access to these services are really difficult. It's not an easy thing to do at all. And you'll hear issues around young people and children who have expressed thoughts about gender dysphoria, perhaps, or have raised concerns about their gender. And hysterical people will start saying, "Oh, we shouldn't be transitioning people pre-puberty." But you need to know that we're not entering into these medical pathways lightly. And in all cases, talking therapies are going to be offered first before any other interventions are administered in a safe way. So I spoke a bit about how do we know whether somebody's trans or not in the room. You can't assume someone's sexual orientation or gender identity just by looking, of course. And one of the ways that we can open the door to conversations around um, gender, especially, is through pronouns and using the right pronoun and asking somebody what their preferred pronoun is. And you'll probably remember that when I started this presentation today, I did say at the beginning, "Hi, I'm Ben Heyworth, and my pronouns are he and him." And it's as simple as that. So, for somebody like me who's cisgender, just popping my pronouns in a bracket after my name and stating them clearly at the beginning will have a big impact if somebody who is trans is listening to this presentation, because they'll immediately think, right, I'm in safe ground here because it's okay to talk about gender. It's okay to say what my preferred pronouns are, and there's a very high chance that people will respect what my preferred pronouns are. Great. What could possibly go wrong with that? People do have a bit of an issue around gender neutral language. And there is the concern that if you start to use parents instead of father and mother, that you're somehow cancelling a parental role, a maternal role, for example. Um, and there is an appropriate use of, in my opinion, of gender neutral language. And you have to judge it as a healthcare professional yourself, because we don't want to stop using the word mum. My goodness, we would never do that, would we? Just on the basis that it's somehow not trans inclusive. But there are ways of creating inclusive services and using inclusive language and using gender neutral language appropriately that brings everybody with us in a positive way and a safe way and an inclusive way, and it's not that difficult to do. I think the best way to practice using appropriate gender neutral language is to tell the story of your day. Let's say what happened between getting out of bed this morning, having your breakfast, going to work and listening to this presentation. Try to describe that in a gender neutral way. Just tell the story. What were your interactions? Who did you interact with? But instead of saying he and she, use they and them. For example, did you speak to your mum on the phone last night? Well, perhaps you could say, I spoke to my parents on the phone last night, or something like that. I'm riffing slightly there, but give it a go. It's not frightening, it's not scary, it's not difficult, it's not going to cancel anybody, and it's going to be inclusive and useful and something to take forward as an immediate win when you're in your professional role. Okay, so we've reached the end of the first part of the presentation. I hope you've enjoyed it so far. Just to summarize really quickly, significant proportion of the LGBT community will use labels to define themselves. We should view labels as a chance to find out more about the patient and their needs. So we're not just asking for a bunch of labels for the sake of it. It's a window, it's a door to open so that we can say, right, you describe yourself as X, Y, and Z. Let's unpick that in relation to the issues that need to be discussed today. It's okay to ask. It's okay to make mistakes. You must avoid making assumptions. Don't assume anything just because somebody looks a certain way, talks a certain way, or behaves a certain way. You cannot tell a person's sexual orientation or gender identity just by looking. And at this point, we will be breaking for a cup of tea and a biscuit. But in lieu of that, I'm just going to have a little sip of water. Thank you very much. And now we're going to move on to part two. So part two is around LGBT health. And as I said at the beginning, we've split it up into certain sections. It'd be impossible to cover every single detail about an LGBT person's potential health concerns in the next half an hour or so, but we can certainly look at some of the big hitters and where there are particular health inequalities that present themselves. So we'll define what we mean by health inequality for anyone who's not sure about that initially. Then we will talk a bit about mental health. Then we're going to move on to sexual health, then some of the smoking, alcohol, and drug-related issues. We're going to talk a bit about how discrimination from healthcare professionals plays out and what the statistics are telling us is going on there. And last but by no means least, we will talk a bit about cancer and cancer screening at the end. So moving on, Health inequality. So I'm going to make an assumption here that most of you will have a reasonable idea of what we mean when we talk about health inequalities. But it's not a bad idea just to have a little look at the WHO definition to remind ourselves, which is on the slide. I'm going to read it out. It says, differences in health status or in the distribution of health determinants between different population groups, producing avoidable and unfair distributions resulting in health inequalities and leading to inequity in health. So what are they talking about there? They are talking about how different elements impact to create avoidable and unfair distributions in health outcomes. That's what I'm picking out of that, but it's rather complicated. I quite like this one that's written under health inequalities in oncology. This is talking about cancer, of course, and specifically survivorship, but it's much clearer. It says, although there are multiple risk factors, there is increasing recognition that people's social characteristics play a part in quality of life and survivorship, where some groups of people have different experiences or outcomes for cancer. These differences are known as cancer inequalities, and they include lesbian, gay, bisexual, and trans people. I think that is a much clearer way of describing what we mean by a health inequality. And at this point, I would like to describe the experiences of a patient who was given us permission to talk about their cancer treatment and their experiences of being on a ward, to illuminate some of the health inequalities that arise from being a gay man. Okay, so this chap is called Dean Eastmond, and this is his story. Well, I should say before I read this out that Dean has given us permission to use his story and his name as part of this presentation today. Dean revealed he had issues with the consent process at a sperm bank he attended before undertaking chemotherapy. He says, I brought up in conversation the fact that I'm gay, and the nurse lifted an eyebrow and said, oh, this applies to straight people. Being told that if I died, my male partner would not be able to use the sperm sample when a female partner could, felt like another slap in the face, another systematic discrimination against you as a gay person. The fact that an LGBT family or family to be out there would be in that position and wouldn't be able to have children in this way is horrendous. Now, the good news is that a solution was found for this issue, and the Human Fertilization and Embryology Authority later clarified there was a loophole which would allow Dean's partner to have the option to use his sperm in the future. But we don't want loopholes, really, do we? Loopholes are not going to solve the problem presented by Dean in this situation. What we need is equity and equality. We need people to know that just because they're in a same-sex relationship, they can still have the same service that heterosexual patients would be able to enjoy. A classic systemic health inequality there from Dean. Dean also talks about people making assumptions and staff making assumptions about his sexual orientation on the ward. And this is what he says. I love how nurses assume I'm straight despite my pink cushions and pink lemonade and copious episode of RuPaul's Drag Race. I could vogue my way through the ward attached to my drip stand and they'd ask how my girlfriend is. Now, for those of you who don't know, voguing is a particular style of dance that's associated with clubs in New York City in the 1980s. And of course, Madonna did a big record about it and does have some gay connotations attached to it. But I won't dwell on that any further. But the point is, of course, that for some reason, these nurses were blind to Dean's presentation. It does make you question how good their person-centered care actually was, if this is Dean's comment about how he was bringing his authentic self to the ward and they didn't notice any of it whatsoever. However, when staff learnt more about Dean, they were able to engage. Now, Dean is a bit of a writer and he had this blog, and this is where I'm getting these quotes from. So there you go. It's such a good feeling when nurses tell me they see their gay friends sharing my blog posts online, and my doctors have been setting my writing as compulsory reading for medical students. despite being in chemo, it's put me in such a good mood. And I could not be a better example there of how someone who is able to be their authentic self and is seen as their authentic self by the people who are supposed to be caring for them has had an impact on his psychological and emotional well-being. And as we all know, if you are going to do well in cancer treatment, it's not always about physical health, it's also about your psychological health. The two come hand in hand, body and mind. Dean put himself in a good mood as a result of being able to be himself on the ward. So that brings me neatly on to mental health. Now, this is from a Stonewall report, LGBT in Britain, and this makes for pretty grim reading, I'm not going to lie, and almost to the point where I'm questioning it, thinking, is this for real? But it is true that poor mental health is rampant in the LGBT community. And here are some of the statistics to support that. Half of LGBT people, 52%, said they'd experienced depression in the last year. 1 in 8 LGBT people aged 18 to 24 said they'd attempted to take their own life in the last year. Almost half of trans people have thought about taking their own life in the last year. 31% of LGBT people who aren't trans said the same. 41% of non-binary people said they harmed themselves in the last year, compared to 20% of LGBT women and 12% of GBT men. There's clearly a lot of work to do to support the LGBT people and the LGBT community to improve their mental health. Now, when you think about LGBT, you often think about sexual health. The first thing that pops into most people's minds is sexual health, isn't it? And the reason for that, of course, is because HIV is associated with gay and bisexual men specifically, and it's true that that HIV has been a significant, possibly the most significant health challenge faced by the gay and bisexual men community since the 1980s, and it's only recently that we've been able to start really, in my opinion, getting on top of it. But it's true that HIV continues to disproportionately affect the LGBT community. And for those gay and bisexual men who lived through the crisis, because it was a crisis around HIV in the 80s, it's an experience I think they will never forget and will take with them everywhere they go, and with every interaction they'll have with a healthcare professional in the future. It'll inform everything that happens going forward. But there is a positive story around HIV, and this is around the treatments that have been developed for HIV. It's possible now for people to have a particular combination of drugs that reduces the amount of the virus in their bodies to what we'd call undetectable levels, which of course will have a benefit for somebody's own health, but more importantly than that perhaps means that the chances of passing HIV to somebody else during sex are effectively close to zero. So it's possible now for somebody to be HIV positive but to have an undetectable level of HIV virus, and therefore they will not be a vector for transmission of HIV during sex, which is brilliant because it will cut down the number of new HIV infections substantially, and that it can only be a good thing. And if you wanted to find out more about that, there are several HIV charities offering information and guidance around what it means to be undetectable. And of course, I should mention that the knock-on effect about having undetectable levels of HIV is it will reduce the stigma that is associated with being HIV positive. And if you reduce the stigma, then you are likely to have an impact on mental health because people will feel less stressed, less stigma, less potential for discrimination, less stress, improved mental health. And as I've already mentioned on the previous slide, anything we can do to improve the mental health of the LGBT community is for the good. I've just put a small comment on the topic of sexual violence on this slide, and I'll be honest with you, this is not an area of expertise of mine specifically, but I was struck by this figure of 42% of lesbian and bisexual women reporting experiencing sexual violence, with half of those women from a Black and minority ethnic backgrounds, which just seemed like an appallingly high number of people experiencing sexual violence from that community. And I think there's some more digging and some more research to be done by me and by anybody else who's interested into that statistic there. And I've got that from the LGBT Foundation, and there is some work done both at the LGBT Foundation and other important charities around responding to the challenge of sexual violence, which I think was well worth a read and will definitely have an impact on how people present themselves, when they're coming for cervical screening, let's say, or some other health issue that might intersect with their sexual health. And last but by no means least, a comment here about information and representation. And this is a really common problem, an easy to solve problem, and something we should all be looking at as healthcare professionals, and that is around how heteronormative and cisnormative is your information that you give to people. Now, particularly around sexual health, there tends to be lots of information for cisgender and straight individuals, but not so much in the mainstream for LGBT people, although that is slowly changing. And of course, given all the different challenges that I've talked about in relation to sexual health in the LGBT community, it's really important to have some quality information that really gets into the community, outreaches into the community so that people can deal with some of the challenges that are out there. So, moving on quickly to some of our public health issues. And I just wanted to highlight some interesting work around smoking, alcohol, and drug use in the community. Now, in line with trends in the general population, LGBT people smoking, alcohol, and drug consumptions vary according to age. So, older LGBT people are more likely to be drinking alcohol almost every day than younger people, whilst younger LGBT people are more likely to be smoking and potentially taking drugs. But the point is, the prevalence of all these behaviours is fractionally greater in the LGBT community. Now, I'll just take smoking as an example. It's a while since I've done any detailed work around the prevalence of smoking in the LGBT community, but we did have this integrated household survey in 2016 that was guiding us a few years ago, pre-COVID, on these issues. And one of the more shocking statistics that came out of that was the fact that a third of lesbian and bisexual women reported that they were smokers. A third, that's an awful lot of people, and hugely more than the comparative figure for straight and cisgender women, which is around 15%. So there is a big gap between lesbian and bisexual women and cisgender and straight women when it comes to smoking that needs to be addressed. Now, when it comes to men, gay and bisexual men, there was also evidence to suggest that they were disproportionately affected by smoking, but there has been some work done pre-COVID, but just before COVID hit, that kind of suggested that we were starting to narrow the gap a little bit around smoking prevalence in gay and bisexual men. So there's some good news to come out of that, but I suspect that there's still quite a lot of work to be done to really challenge the health inequalities linked to smoking in the LGBT community, and it has gone a wee bit quiet on that issue as a result of COVID, and really needs to be resurrected. And the third issue that I've highlighted on this slide around drug use is something called chemsex, which is another of these issues that is associated with gay and bisexual men. And this is a term commonly used to describe sex that occurs under the influence of drugs, which is taken immediately preceding and or during the sexual session. Now, the drugs that are commonly associated with chemsex you'll definitely have heard of some of them. This one here, crystal meth. You'll have heard of that, I'm sure. This is a crystalline substance that is smoked to a sort of glass pipe and makes you feel very euphoric as a result. And there's also this other one here, GHB and GBL, which is a clear liquid, which is usually drunk in very small quantities, so 1 milliliter, 2 milliliters at a time, no more than that over the course of an hour or so, with a small dash of Coca-Cola or other mixer so you don't get a horrible burning sensation in your mouth. And that does make you feel very sexual and very open to sexual activity. And obviously, combined with crystal meth, could be a very potent combination. Methadone is in there as well. That has a very similar impulsive effect. And also cocaine and ketamine are drugs that might be associated, but to a lesser extent than those others. And the interesting thing about chemsex is that quite a lot of gay and bisexual men will indulge in these kinds of activities, but remain functional, and they'll be getting up to go to work on a Monday morning as if nothing's happened, because whilst they can be very intense experiences and last for quite a long time in some cases, if you're smoking a lot of crystal meth, it can go on for ages because it keeps you awake. They're still functional in life in general. So it's not always associated with adverse physical, mental, and social harms, but you do have to question the physical and psychological impact of that activity if it becomes regular, frequent, possibly very addictive, and could cause some real harm in the medium to long term. But it's a very interesting area of study, and something, if anybody is interested in LGBT health, that you ought to investigate. So moving on to talking about discrimination from healthcare professionals, and this is another one where you sit back and you look at the figures and you think, gosh, that's so awful, it can't be right. So it's a bit negative, this slide, unfortunately, but it's worth just whizzing through the list of issues that are presented here. We have 1 in 8 LGBT people experiencing some form of unequal treatment from healthcare staff because they're LGBT. 1 in 8. I mean, that's an awful lot of people. We have 1 in 4 LGBT people witnessing discriminatory or negative remarks against LGBT people by healthcare staff. In the last year alone, 6% of LGBT people, including 20% of trans people, have witnessed these remarks. We have 1 in 20 LGBT people pressured to access services to question or change their sexual orientation when accessing healthcare services. Quite recently in the news, there's been some controversy around conversion therapies, which is around the enforced attempt to change someone's sexual orientation or gender identity, coercive, psychological, harmful, and absolutely something that should be banned. I don't know why it's not banned already. Terrible behaviors and really needs to be shut down immediately. 1 in 5 LGBT people aren't out to any healthcare professionals about their sexual orientation when seeking general medical care. So why might that be? Are they afraid? Have they witnessed discrimination before? What's preventing them? Is it the right sort of language being used? Is the wrong sort of language being used? This number rises to 40% of bisexual men and 29% of bisexual women. So what we have there is the virtual erasure of bisexual identities, because so many bisexual people are unwilling to disclose their sexual orientation for whatever reason, whether they feel safer keeping it to themselves or whether they feel that they're not going to get the response that they might expect if they disclose their sexual orientation. So moving on, cancer and cancer screening. We've touched on this a little bit quite a lot already, haven't we, in other contexts? I've mentioned cervical cancer screening a couple of times during the course of this presentation already. But we know that LGBT people are at greater risk of developing some cancers. We've already spoken about the smoking prevalence, alcohol and drugs in the previous slide, and also higher levels of obesity are reported by the LGBT community, which we know is a key driver for certain cancer types. There's also an issue around cancer risk as a result of hormone treatments in trans people, which we would probably need a medical expert to guide us around. And there are a few of those knocking about. If anyone's got any particular questions around cancer risk and hormone treatments, I can point you in the right direction. And rates of screening in the LGBT community are generally lower. So we've got some data on the slide here, 71.4% uptake in the UK. Trans men, some trans men, of course, will still retain a cervix. So we've got 27% attendance versus 43% cis women attending, which low numbers for both there, but diabolically low numbers for trans men. Amongst the lesbian and bisexual population, we've got 17.8 never attending a screening in the UK versus 7% in the wider population of women. So there's a huge health inequality creeping in there around cervical screening. So I mentioned I was going to talk a little bit about some intersectional issues that crop up around being LGBT, but also being in another minority group. And on this slide, it talks about Black, minority, ethnic, and people of colour. And again, some statistics that are worth reflecting on a little bit. 51% of Black and minority ethnic LGBT people report having experienced racism from within the LGBT community. This number rising to 61% for Black LGBT people. And you may not remember this, but a few years ago, we had a change to the rainbow flag. Now, the rainbow flag is the key kind of signifier of LGBT, and you'll see it above bars, and you'll see it on people's lanyards and t-shirts and websites and everything. LGBT, rainbow flag, pride, all goes together as a thing, and that's how the community represents itself on a flag. But what wasn't on there was the black and the brown stripe that is on there now. And putting the black and the brown stripe on the LGBT queer rainbow flag was a response to the reports of racism within the LGBT community, essentially. And that's now there. So if you see a rainbow flag at this year's Pride and look for the black and the brown stripe, and you'll see that very visible response that was done to support people of colour from the LGBT community to tackle this kind of internal racism. Moving on, BAME people, LGBT people are about twice as likely to attend LGBT specific venues or events as white people, 45% compared to 22%. And perhaps there's implications for community-based healthcare spaces there. I'm not sure about that one. It's just a suggestion, probably a discussion point if this was being done live. What do you think? I'd be interested to hear your views. A third of LGBT people of faith are not open with anyone in their community about their sexual orientation. And 1 in 4 for trans people of faith are not open about their gender identity. Not being out could result in, as we've seen, increasing health inequalities. Why aren't they out? Well, perhaps they're afraid of the reaction they might get from more conservative members of those religious communities, perhaps. 62% of Black and minority ethnic LGBT people report suffering from depression. And we've already talked at length about the epidemic of mental health problems in the LGBT community. And 1 in 5 Black and minority ethnic LGBT people have experienced unequal treatment from healthcare staff because they're LGBT compared to 1 in 8 LGBT people from other groups, which is very interesting and another statistic to keep us awake at night. LGBT and older adults. Now, time is ticking on, so I'm not going to go into detail on each one of these points, but I will point you towards this brilliant report done from Marie Curie called Hiding Who I Am, the reality of end-of-life care for LGBT people, which you can look at online by visiting the Marie Curie website. And if you have a particular remit around palliative and end-of-life care, looking after older adults or frailty, this would be the publication to get your hands on, and it's very, very good and very current, even though it's been around for a while. And the sorts of things it talks about will not be a surprise to you because we've discussed them at length in this presentation already. So, for example, anticipating discrimination, going back into the closet when you go into a care home, concerns that you won't be able to bring your authentic self into a new environment because you're worried about what the staff and what the other patients might think. Complexities around religion and LGBT end of life. Well, I just mentioned a moment ago about some people keeping themselves out of the spotlight because they're concerned that they will encounter conservative views in particular faith communities and from their own family potentially as well. That brings us on to the next point there. Assumptions about identity and family structure are often made, and sometimes the LGBT person who has a same-sex partner that the family don't like, don't recognise, can be very, very difficult, and these tend to come out the woodwork at end of life and moments of crisis. So for the final section of the presentation today, I'm going to talk about how we might want to address some of the inequalities that we've been talking about during the presentation so far. Well, we need to know who our LGBT patients and carers are, but how are we going to do this? Well, we're going to ask the question. There is a sexual orientation monitoring information standard that went live on October the 5th, 2017. And it does provide a consistent mechanism for recording the sexual orientation of all patients and service users aged 16 years or over. What does it look like? Well, it's a bit clunky, a bit complicated. It does bring us back to that conversation we had at the start of the session today around labels. It's asking which of the following options best describes how you think of yourself. So we have 1, heterosexual or straight, 2, gay or lesbian. They can be lumped together because, of course, this is not a question about gender identity. 3, bisexual, because we spoke a bit about bi erasure. Very important to have them front and center as an option. And we have 4, other sexual orientations not listed. And you remember we talked a bit about asexual people and pansexual people. And there's other options there around people who don't know or who don't want to answer. Now, I think that needs to be slightly simplified. This is my version right here. Which of the following options best describes how you think of yourself? Heterosexual or straight, tick a box. Gay or lesbian, tick a box. Bisexual, tick another box. Or in another way, please state. Prefer not to say. You can add it if you want. I personally don't, because I think it gives people an opportunity to skip answering the question, which we'd like to avoid. But if you feel strongly it needs to be included, that's fine. What about trans status monitoring? Well, include diverse gender identities in your gender multiple choice question as follows. So this is trans inclusive. And we have which of the following best describes your gender? Man, including trans man, woman, including trans woman, non-binary, in another way. Now that doesn't tell us who is trans in the room, so we need to add another question at the bottom. Is your gender the same as the gender you were assigned at birth? Yes or no? Very simple. And that's a trans inclusive way of asking about somebody's gender identity without cancelling anybody, and also letting us know who is trans in the room. Now then, we're getting towards the end of it. If you want to hear some more stories from people affected by cancer who identify as lesbian, gay or bisexual, you can find them here at lgbcancer.wordpress.com, and it's a really good resource from Macmillan, exploring loads of the issues that we've talked about during the course of the presentation. And I think you'll find it very illuminating. So if you do get a chance, visit that website. And I'm going to throw a few questions at you to kind of finish off today. Now, obviously, if you were in front of me, we could have a chat about these, we could talk about them. But as you're not, perhaps you can go away and reflect a bit on these questions in your own time. So, the first one is around how we can be innovative and effectively engage organizations and staff around LGBT issues. And the reason why I've thrown this one in is because we've talked a lot about staff discrimination and how staff respond to LGBT people and the lack of training that's available around LGBT and health. So there's definitely something in that I think needs to be discussed and needs to be discussed in your organization. How can we empower ourselves to harness the strength of diversity? And this is really a good question, I think, because diversity is strength. If you have people with different views, different thoughts from different cultures, with different languages and different ideas coming together, your organization is going to be stronger for it. And it's how do we harness that? How do we make that a central part of what we do for the good of everybody? A challenging question, I'm sure you'll agree. How can we effectively use signs, symbols, images, and representation to indicate support for the LGBT community? There's some fine examples on this slide just here. Uh, Tottenham Court Road for Pride, no doubt, with a little rainbow on its logo. We've got policing with pride. I don't find that tokenistic. I find that empowering to see police cars with strong pro LGBT messages on there because, historically, LGBT people have faced discrimination and harassment from the police. So we've moved a long way over the last 40 to 50 years in our relationships with the police and the police authorities. At this point, I'd say any questions, and of course, you'd all put your hand up or take yourself off mute and hit me with some hard-hitting, difficult, and challenging questions. But we don't have that option today. If people do want to ask a question, then you can do so by contacting me at benjamin.heyworth@nhs.net. And I do welcome people contacting me with any thoughts, comments, ideas, queries, questions that might have grown out of this presentation today. And I hope you've enjoyed listening to me talking about the challenges faced by the LGBT community as regards to their health. I hope you found it interesting and stimulating. Thank you.